Hello. Today we are going to look at the appendicular skeleton. Your appendicular skeleton involves your arms, your legs, and anything that attaches your arms and your legs to your trunk. So that would be your pectoral girdle and your pelvic girdle, as they both attach. Your pectoral girdle attaches your arms to your body, and the pelvic girdle attaches your legs to the body. So what makes up that pectoral girdle? That pectoral girdle is made up of your clavicles in the front, or your collarbones. Those are called the clavicles, and your scapulae in the back, or your shoulder blades, as they're also known. So those clavicles and that scapula are attachment sites for muscles. They let you move your arm around. They actually let your arm move and have great mobility, because the scapula, if you raise your arm up over your head, your scapula actually rotates with it. The socket that fits your arm to your shoulder is very narrow, shallow. So your arm can actually go really high up and over. It doesn't restrict any of your movement. So here is the pectoral girdle. It has your clavicle, the scapula in the back, and where the clavicle and the scapula actually come together is called the acromioclavicular joint. So let's look a little deeper into each of these bones. So your clavicles, as I said, are also called your collarbones. That's the common term for them, but it's kind of in an S shape, where it has an end that's called the sternal end. This is what articulates with your sternum in the middle. And it has kind of a flattened part at the other end of this S-shaped bone called the acromial end, because it articulates with the acromial process of the scapula. These all anchor muscles, they hold muscles together. They also help keep your scapula attached to your back and your clavicle attached to the front part of your body. So here is a clavicle. We're looking at it from two different angles. We have a superior view and an inferior view. On this clavicle, you see the sternal end. That's on the medial side. That's where it attaches with that sternum. We have the acromial end. That attaches to that scapula, the acromial process. And if we look from the other view, so that picture on the bottom, that inferior view, of course, it has that flat sternal end. That flat sternal end is what articulates with, of course, the sternum. And then we have the acromial end. Again, it articulates with the scapula. There are different lines or grooves on the clavicle. You don't need to know what they are, but just know that anytime you see like a line, like the trapezoid line, that's where a muscle attaches. That's where the trapezius muscle attaches. So that's scapula. Your scapula sits on your back. You have two, one on the right, one on the left. It's kind of a triangular shaped bone. And each scapula, it has three borders. It has three angles. And it actually sits between ribs 2 and 7. So if we look at the three borders here, we have the superior, medial, and lateral. That superior, of course, is superior means up, so it faces up. The medial side, it runs parallel to that spine. It is pretty straight line actually at the medial side. And then the lateral, where it faces that axillary, or your armpit. That is actually where the glenoid cavity sits. That glenoid cavity is where your arm, or the humerus, which is the bone in your arm that articulates with that scapula. It's in that glenoid cavity is where the head of the humerus will sit in there. We also have 3 angles. We have the superior angle, the lateral angle, and the inferior angle. We'll look at those when we look at the picture of the scapula, but let's look at the different features on the scapula first. So we have a spine. If you remember from the spinous processes in your back, the spine of the scapula is what sticks out further. We have an acromion, which comes together with the clavicle to make the acromioclavicular joint. We have a coracoid process. Then we have a suprascapular notch. So here is the scapula. We have the different borders. So we have that superior border across the top, the medial border. As I said, that medial border is more of that long side. This is what faces your spine. Then we have our lateral border. This is the lateral border here is what faces out to the outside, more closer to your arm. We have those 3 angles, the superior angle, the inferior angle, then we have this glenoid cavity. In this glenoid cavity, this is where your arm attaches and makes your shoulder joint. We have the acromion and the coracoid process. Let's look at it from another angle. So here's this acromion from looking at it from the posterior view. We still have that superior angle, your inferior angle, and then we have that glenoid cavity at that lateral angle. We have our lateral border, medial border. Remember, medial border faces the spine. We also have that superior border. We have what is called that suprascapular notch. That's right in here. This suprascapular notch is where nerves, arteries go through, and there's actually a ligament that crosses that. You don't need to know the name of that ligament, but there is a ligament in there to help hold things in place. As I mentioned, the spine. This spine is this whole thing right here. It sticks out on the scapula. And you can see from this angle that coracoid process. Here's another angle. Now we're looking at it as if you're looking from the side straight into somebody's shoulder. So again, that acromion, you can see that. You can see how the coracoid process, that glenoid cavity. So this is where that humerus articulates with the shoulder, that your arm bone. We have the inferior angle. We see the spine of the scapula. You can see how that sticks out so much. So you can feel that on people's backs. And that's what you need to know on the scapula. So let's look at our upper limb, or our arm. Your arm is also known as an extremity. So if you ever hear that word, they're talking about your arms, or they could be talking about your legs, because your legs are also known as extremities. And I tend to say that word a lot too, so I wanted to make sure you know what it meant. Your arm. Each arm has a total of 30 bones. That's a lot. You have your humerus, as I mentioned before, that's the bone in your arm. Your radius and your ulna, those make up your forearm. And in your hand, you have 8 carpal bones, 5 metacarpal bones, and 14 phalanges. So let's look at these. Your humerus. So we have technically 2 humerus bones, one on each side. It is the largest bone in the upper limb or your arm. That humerus is what it articulates with the glenoid cavity of that scapula. It's pretty important. And at the inferior portion, or the distal portion of the humerus, it articulates with the radius and the ulna. So, as we're going to learn, most bones, extremity bones anyways, has a head. Your humerus has what's called an anatomical neck and a surgical neck. That anatomical neck is just past the head, just distal. Well, the surgical neck, it was given a name because it is the most frequently fractured part of that humerus. That's why it was given a name. We have a greater tubercle, a lesser tubercle, and between the two tubercles in the humerus, we have an intertubercular sulcus. Inter means between, tubercular between the tubercles, and it's a sulcus. We have a deltoid tuberosity, which is about halfway down. That's where the muscle, the big muscle in your shoulder, attaches. We have a radial groove that kind of goes on the underside. That radial groove is where that radial artery or nerve, there is an artery that follows that too, but the radial nerve is the main one that follows that groove. We have a trochlea, capitulum, medial and lateral supracondyle ridges, a coronoid, olecranon, and radial. So let's look at all of these. So here is your humerus. The head of the humerus. This is what articulates again with that glenoid cavity of the scapula. Here you see the greater tubercle from this angle. Here you see the greater tubercle, the lesser tubercle, so that greater tubercle, that lesser tubercle, and between it, you have the intertubercular sulcus. So that's this whole divot through here. As we said, just past the head is the anatomical neck. But the surgical neck is below those tubercles. You can see that deltoid tuberosity. You see that radial groove, this kind of groove that follows the bone? That's where the nerves, the radial nerve follows. We have the deltoid tuberosity. Then we're going to have a lateral supracondylar ridge. We have a medial and lateral epicondyles. The epicondyles are the lower part of the bone here, while the Supracondylar ridge is more through here. That is important just because there's muscles that attach there. We have this radial fossa. You can see it kind of right here. You can also see it right here on this drawing. We have our coronoid fossa, which sits more in here. We have what is called the capitulum. The capitulum here is what articulates with the head of the radius. So when you bend and straighten your arm, that radial head actually goes into this radial fossa here. We also have a trochlea. You see it from the different sides. Let me get a different color. We have the trochlea from this side and the trochlea from this side. That is what actually articulates with the olecranon of the ulna. So here's a closer view where you see the radius, you see the ulna and how it articulates to make your elbow joint. So let's look. See, up here is our humerus. You have your coronoid fossa. So we have a coracoid and a coronoid. Coracoid process, coronoid fossa. That coronoid fossa articulates with the coronoid process of the ulna, which is this part right here. So when you bend your elbow, it will articulate there. You see the head of the radius will articulate with the radial fossa here when you bend your elbow. And again, that radial head will articulate with the capitulum while the ulna articulates with the trochlea. So now we can see if we look at the next picture, we see, again, you see the olecranon fossa. That's where the olecranon articulates. So when you straighten your arm, this whole thing stops your arm straight, so it will not go any further. And we always have our medial and lateral epicondyles. You can see the ulna on the left side, and on the right side, we have the head, the neck of the radius. You can also see from picture D back over here, we have this tuberosity. That's your radial tuberosity. That is where the radius and the ulna articulate. So let's look more at our forearm. We've looked a little bit at the radius and the ulna that make up the forearm and how they articulate with the humerus. And we even looked at how they make the proximal radial ulnar joint. They also have a distal radial ulnar joint. They are radius and the ulna actually are connected together by an interosseous membrane, and it follows the entire length of those two bones. So we've looked at some of these already, but the ulna has the olecranon and the coronoid process. They have the trochlear notch, radial notch, ulnar head, and the ulnar styloid process. The radius. We have a head, the radial tuberosity, ulnar notch, and the radial styloid process. So let's look at these. So let's first look at how the bones kind of articulate together. This time we don't have the humerus attached, so we can kind of see the bones better. So we have the olecranon. Again, that's like that hook. Is that top part of that hook that'll attach to the humerus is the olecranon. On the other side of that, the hook at the top part up here, at the bottom part, we have a coronoid process. Same over here. We have, as I said, we have that proximal radial ulnar joint where the head of the radius articulates with the ulna. At the radial notch, the head of that radius, it's a flat, round piece. The neck, just like any other bone, the neck is just below the head. Then we have that radial tuberosity. It's kind of in here. This is that radial tuberosity. Again, a tuberosity is a nice bump. Now, as we follow the bones down, the ulna actually stays pretty thin throughout, while the radius at the distal portion gets thicker. It gets bigger. The head of the radius is small at the proximal end, and that distal end, the radius is a lot bigger, thicker. So we have that radial styloid process at the bottom, and we have an ulnar styloid process. And how we talked about between the radius and the ulna all the way through, we have this interosseous membrane that helps to hold them together. Now we've kind of talked a little bit about, we have the head and neck of the radius is at the proximal end of the bone, so closer to the body. For the ulna, the head is actually on the distal portion of the bone. It's closer to the wrist. So we have the ulnar notch of the radius, and that's what forms that distal radio-ulnar joint. We have this radial styloid process and the ulnar styloid process. You can feel those styloid processes in your wrist. So let's get a closer look. So this is our ulna, and picture D here. You see that olecranon? The trochlear notch, that's what articulates with the trochlea of the humerus. That coronoid process at the bottom or distal part of that hook at the top of the ulna. And then you see that radial notch. That radial notch in here is what articulates with the head of the radius. Now, if we look, picture E gives us the distal end. This is closest to the wrist. So down at the bottom, we have an ulnar notch for the radius. That is where the head of the radius will articulate with, or the head of the ulna, sorry, the head of the ulna articulates with the radius. And you can see that ulnar styloid process, that radial styloid process. And then you don't need to worry about knowing the specific names of the wrist bones. You just need to know that they are carpal bones. So there's specific names when bones break. It's called a Colles fracture if the distal portion of the radius fractures, if it breaks. if you've ever tripped, fallen, and put your hands out as you're falling down face forward, face first, try to catch yourself with your hands. This is how that fracture usually happens. You're falling forward face first, you put your hands out, try to catch yourself, and it fractures your radius. It can also fracture some of the carpal bones or the bones in your wrist. That's why I was always told to tuck and roll when you try to do that. So let's look at our hand and our wrist. Our wrist is made up of carpus or carpal bones. The palm of our hand are metacarpus or metacarpal bones, and then our fingers are called phalanges. That's what you need to know them as. Carpal, metacarpal, and phalange bones. You don't need to know the specific names. So as I said, the carpals are your wrist, metacarpals are the palm of your hand, and those phalanges are your fingers. Your phalanges are technically named 1, 2, 3, 4, 5. Except your thumb has that name of pollex that we learned in chapter 1. But your thumb is technically 1, your pointer finger is 2, middle finger is 3, ring finger is 4, and your pinky finger is 5. That's how they are normally named. And then fingers 2 through 5, so your pointer, middle, ring finger, and little finger all have 3 bones for the phalanges, while your thumb only has 2. So your thumb has a proximal and a distal, while the other 4 fingers have a proximal, middle, and distal in your hand. So here is the hands, your carpals or your carpal bones. You just need to know that these bones right here are your carpal bones that make up your wrist. The metacarpals are the palm of your hand. So these are your metacarpal bones. Your phalanges, those are your fingers. So here are your phalanges. That's all you need to know the bones of your hands as. So, I'm sure you've heard of carpal tunnel syndrome. Carpal tunnel syndrome affects what is called the median nerve and the tendons that go through that carpal tunnel. There's a tendon that goes over those carpal bones, and that median nerve goes between the bones and that tendon. So as that median nerve goes to the hand, if you get inflammation in that area, usually in the tendon, it can compress that median nerve. It can cause tingling in your fingers. It can cause numbness in some of your fingers. It can cause weakness where you can't really hold on to anything. That's all signs of carpal tunnel in your hands. So let's move to our pelvic girdle. The pelvic girdle is what holds your legs to your trunk. So there's technically two hip bones or coxal bones, and those coxal bones attach to the sacrum. So as I've said, they attach your legs to your skeleton, to your trunk. They're held together with some nice, strong ligaments. Your pelvic girdle helps to support your pelvic organs. Your hip is not as mobile as your shoulder. And we'll kind of look at why that is. Because your shoulder, you can raise your shoulder up to 180 degrees in multiple directions that you cannot do with your leg. So the reason why your coccyx or coxal bones are made up, technically it's made up of 3 bones. Because technically they are 3 bones when you're born, and they eventually fuse together as you get older. So the place where the femur or the bone of your thigh actually articulates with that pelvic girdle, it's called the acetabulum. That acetabulum, it's a lot deeper of a socket that your head of the femur fits into. So it actually makes your hip more stable. So let's look at this pelvis here. We have our base of the sacrum. We have our whole sacrum in here. These joints right here, these form joints. And those joints are what connects these hip bones or coxal bones to the trunk, to your spine, to that sacrum. Our different bones, we have our ilium, pubis, and ischium. Along the top, this is called your iliac crest. The joint that connects that hip bone to the body is called the sacroiliac joint. We have an anterior superior iliac spine right through here. You can see it really well on this side too. We have an anterior inferior iliac spine through here. You see it along here. We also have that acetabulum. This through here is what connects. This is where the head of the femur sits in that pelvic bone. We have this pubic symphysis that sits right here. This is all fibrocartilage in that pubic symphysis. So as we just kind of looked at, we have the ilium, the ischium, and the pubis. Those are the 3 bones that make up your hip on each side. So we have a greater sciatic notch. I'll show you where that is. That is where, of course, sciatic nerve. We have a gluteal surface. It's where your gluteal muscles attach to that pelvic bone. Iliac fossa. That is where technically you don't need to know that muscle, but it's where the muscle iliacus attaches. Iliac, iliacus. So I said a lot of names kind of relate to each other. You have that auricular surface that articulates with the sacrum. And then you have what's called an arcuate line. You don't need to know that though. On the ischium, the ischium has an ischial spine, your ischial tuberosity, that's your sit bones. That's what you sit on every day. Then your lesser sciatic notch. In our pubis or pubic bone, we have the obturator foramen, which is the largest opening, largest foramen in the body. I showed you the pubic symphysis. In this pubic arch, we will look at this, especially in lab, because that pubic arch is where you can tell the main difference between a male pelvis and a female pelvis. So here's the bones in different colors, so you can see which one is the ilium, which one is the ischium, and which one is the pubis. So that ilium across the top, we have that iliac crest that follows, again, right along the top. We have the anterior superior iliac spine, anterior inferior iliac spine, but we also have a posterior superior iliac spine and a posterior inferior iliac spine. We have a greater sciatic notch, which is made up by this through here. That is your greater sciatic notch. We also have a lesser sciatic notch. Again, sciatic, so what goes through it? The sciatic nerve. Through here. We have your ischial tuberosity. That obturator foramen is this big hole here. And of course, that acetabulum. This whole part in here. So let's look at the other side. I'm pointing out the main features on these bones. I'm not pointing out everything, just the main features. So again, that ilium at the top that has that iliac crest, anterior superior iliac spine, anterior inferior iliac spine, posterior superior iliac spine, and the posterior inferior iliac spine. On that posterior surface, through here, that is what articulates with the sacrum. We have that greater sciatic notch through here. That obturator foramen. There's actually muscles that go through that. I think those are the main things that are pointed out here. You do have those ischial tuberosity right here. That ischial tuberosity, again, are your sit bones. So, in the pelvis, or those hip bones, the sacrum and the coccyx, that makes up the entire pelvis. Females' pelvises are wider. They're shallower, and they're actually a lot lighter. Males' pelvises are a lot rounder. Females need wide pelvises for childbearing so that the child can fit through the birth canal. Let's kind of look at what this is. We have our true pelvis is this whole part in blue on both pictures. We have what is called a false pelvis. The false pelvis is the superior brim is this reddish orange kind of color. That is just more of where the hip bones sit. That's really all it means. So let's look at the difference between a male and a female pelvis here. So a female pelvis, we talked about that pelvic arch or pubic arch in a female. Look at how wide that pubic arch is versus a male. It is very narrow. That is the fastest, easiest way to tell if it's a male versus a female pelvis. The female, that pubic arch is very wide. On the males, it is very small. But if we also look at this in here, it's pretty narrow. Through here, it's a lot wider because again, a baby needs to fit through there in a female that it doesn't need in a male. We can also see on a real pelvis in a male that coccyx bone comes down pretty close, while in the female, it stays out wider. That pelvic inlet is a lot wider versus a male's, which is a lot narrower. So a male versus a female pelvis. We have different ones in the lab and we will look at them. So let's move on to the lower leg now. Our lower leg is made up of the thigh, a leg, and a foot. Let's look at the bones that make those up. The thigh is our femur. It is the strongest bone in the body. That femur is the strongest bone in the body. That femur is what articulates with the acetabulum of the hip, and it'll articulate with the tibia and the patella at the distal portion. As we talked about a little bit with the axial skeleton, that's patella is a sesamoid bone because it is found within the quadriceps tendon and it helps to protect that knee joint. We need that for protection. So this femur here, I'm just going to go through the main features. I'm not going to go through everything that's on there because there's a lot of different things on this femur. So we have the greater and lesser trochanters. Of course, we have a head, we have a neck. They have an intertrochanteric line and an intertrochanteric crest. They have a linea aspera, medial and lateral supracondylar lines, medial and lateral condyles, medial and lateral epicondyles. We have a patellar surface, an intercondylar fossa, and we also have the adductor tubercle. So let's take a look here. Let's start at the top. As I said, we have a head and a neck on our femur. The greater trochanter is at the top. On the inside, we have this lesser trochanter. You can see this intertrochanteric crest along here versus the intertrochanteric line over here. That linea aspera. Now to the bottom, the distal portion. So we always have a medial epicondyle and a lateral epicondyle. Those you see more on the side, the epicondyles on the side, while the actual condyle is in here. These are the condyles. So we have that medial condyle and that lateral condyle. We have the patellar surface, which fits along here. So this is be the front of the bone because that's your patella articulates on the front. And we have our patella. This bone is our patella. You just need to know that it is the patella. So here's a chart from your book that looks at all the different parts of the leg from the all the way from the hip all the way down to the phalanges, which are also your toes. But let's keep working. We've got our tibia and our fibula here. Those are the two bones that make up your leg. The tibia is more medial and it carries most of the weight down. So after the femur that carries the weight, the tibia carries most of the weight next. The fibula is technically not a weight-bearing bone and it's lateral. So it's on the outside of the leg. It's just where muscles attach. It does articulate with the tibia, the bone right next to it. So let's go straight to the bones and we'll look at how. So our tibia, since it's weight bearing, it's a lot bigger than this smaller fibula, which is more lateral on the outside. On our fibula, we have a head. You see the head of the fibula here. On our tibia, we have a lateral condyle and a medial condyle. So that lateral condyle, medial, lateral. We have our articular surfaces of the lateral condyle, and then we have the articular surface of the medial condyle. So again, where they articulate with the femur. Just like between the radius and the ulna, our tibia and our fibula have an interosseous membrane. Now let's look at the distal portion. We have a medial malleolus, which is our ankle bone in the middle, and a lateral malleolus, which is our ankle bone on the outside. We have our tibial tuberosity right here or right here. If you look at the tibia bone, it's a pretty roughened up surface. So there is a fracture. We look at this x-ray here. That is called a bimalleolar fracture. Bi means two, malleoli or malleolar, those are the two, that's the medial and the lateral malleolus or those ankle bones. So you can see fracture, fracture. That's pretty painful, but it does happen. So here's some information about it. It's kind of a common fracture in sports. So it happens at the distal end of the tibia and the fibula. Now our foot. There are two bones in the foot that you will need to know. And I will go through those. You just need to be able to identify the bones. We have our tarsals, which are the bones in our foot. We have the metatarsals and our phalanges. The two bones you need to identify are the talus and the calcaneus. The calcaneus is your heel. You do not need to know the cuboid, navicular, medial, intermediate, and lateral cuneiform bones. You just need to know that those are tarsal bones. So let's look. We also have metatarsals. Tarsal is for foot. The metatarsal bones, they form what is known as the ball of your foot. And just like your fingers are numbered 1 through 5, so are your metatarsal and phalanges. So your big toe or the hallux is 1, and then they move 2, 3, 4, 5 towards the little toe. So they start medial and they go lateral when they're being numbered. Just like your fingers are phalanges, your toes are phalanges. Your big toe, digit 1, the hallux, only has that proximal and distal phalanx, while the 2 through 5 have proximal, middle, and distal phalanx, just like your fingers. So here's a foot. That calcaneus here. This is your heel. Then the bone that sits right above it is the talus. These are the two that you need to know their names of. The rest of them are just known as tarsal bones. Our metatarsal bones make up the ball of your foot. Then your phalanges are your toes. So in our foot, we have different arches. There's technically 3. We have a lateral longitudinal, a medial longitudinal, and a transverse arch. They all serve different purposes to help your foot keep the bones in shape, the shape that they're, like the position they're in, to help with moving. They help with weight bearing, because think your feet are carrying the weight of your entire body. So those arches kind of help hold that weight. So here's the different arches. So we have our medial arch, our lateral arch, and then we have what is called a transverse arch. So here you can see the medial arch, that lateral arch, and we have a transverse arch through there. So sometimes people get what are called fallen arches or a flat foot. The medical term for it is pes planus. It could be congenital. It could be obesity. Pregnancy does that. Sometimes when people are pregnant, their feet, quote unquote, grow a few sizes. It's because their arches are falling. It could be from running, from exercising. Like high impact activities can actually cause your arches to fall and your bones to kind of spread out more. That's why it's important to wear good arch support in your shoes. It can prevent that problem. So let's look at the developmental aspects of the skeleton here. So that infant skull, it technically has more bones than an adult skull. And instead of being connected by sutures, they are connected by what are called fontanelles. And those fontanelles are kind of remnants of membranes. Those fontanelles actually allow for an ease at birth because they can kind of condense down to fit through that birth canal. It also allows the brain to grow. That's very important. So we have different fontanelles. We have an anterior fontanelle, a posterior fontanelle, a sphenoidal fontanelle, a mastoidal fontanelle, and that is the 4 fontanelles of a newborn skull. So when the skull is developing, there can actually be some distortions or abnormalities to the skull. The most common one is called a cleft palate. Those maxillary bones don't fuse in the middle where they should, and it leaves a part that's open. Babies can't suckle when they have a cleft palate. It can cause aspiration of food, which is inhaling food into your lungs instead of down your digestive tract. And if you aspirate food, it can result in aspiration pneumonia. So here is a baby with a cleft palate. Those maxillary bones did not connect. The child had it fixed. So you can kind of see where there was a surgery that was done here. But, so it can be fixed. It's the most common birth defect. So if you've ever noticed when you look at a baby, the cranium is pretty big compared to their face. Their head is pretty large. But by 9 months, their cranium, that part of their skull, is half the size of an adult already. That's why kids usually have big heads. Because by the age of 5, all those fontanelles close up. So your arms and your legs actually grow faster than your head and your trunk. That's how we get those adult size proportions. Those arms and legs grow fast. Your trunk it grows, but it grows a lot slower. So here's a newborn skeleton or skull versus a human skull. It's not a lot different. So here is how a child in size grows to an adult. So we looked at the curves a little bit, and I mentioned them in lab. But we have primary curves, which is that C-shaped curve that you see in a baby. All they have is that C-shaped curve. Our secondary curves are curves that are developed as number 1, when the baby does tummy time and picks their head up, then their low back, that curve when the baby starts standing. That's how these curves develop. So here is that primary 1 curve all the way through. So what happens as we get older? Those intervertebral discs in your back actually become pretty thin. They're less hydrated and there's less elastic in them. Remember, you're the tallest when your feet first hit the ground out of bed in the morning. After that, your discs throughout the day start to lose hydration. But as you get older, they continue to lose hydration. So you can lose several centimeters of height by 55 years old. That's not much. We have the costal cartilage can ossify. That's that cartilage that holds your ribs to your sternum. If those start to ossify, it gets hard to breathe. Your bones start to lose mass. It means those osteoblasts are working harder or no, the osteoclasts are working harder than the osteoblasts. So as you get older, you have an increased risk of fracture. As those discs can become thinner, as you get older, you have a higher chance of a herniated disc. So let's look at another common, well, not so common, but another kind of birth defect. It's called developmental dysplasia of the hip, or DDH. It's in about 2% of newborns. So it's not super common, but 2% it's about 2 out of 100 or 1 out of 50. So it can result in a partial or a complete dislocation. So that the head of the femur and that acetabulum, when they develop, it doesn't develop very well. So it's actually found in infants that have a breech, presenting as a breech birth. That's not good. So they usually have to ultrasound the hips. They have to wear some kind of harness, casting, or they end up with surgery. It can lead to what is called degenerative arthritis. It's where the joints, like the joint spaces, get smaller and bone starts rubbing on bone, and it causes a lot of problems down the road. But that is it for our appendicular skeleton and how our skeleton matures. Thank you for listening. Bye.